My name is Leah Fernald. I'm a professor at the School of Public Health at UC Berkeley. And yes, most of my work really involves working in low and middle income countries and focusing on children's development. My hope for today is that I can share some of the lessons learned in a global context and maybe add to your thinking about what we can do for children who are vulnerable and families who are vulnerable. So I will begin with, let's see if this all works. This is great. Okay. We know that poverty is a potent, powerful, has potent and powerful effects on children, and that children living in poverty are exposed to many risks. This is true in Bangladesh. This is true in California. I don't need to tell anybody here about the environmental risks of poor housing, lack of sanitation, exposure to infectious diseases. And then also added to those risk factors are the household level factors of larger family size and household crowding, high levels of maternal depression, and less nutritious foods and malnutrition. The consequences of poverty are dire for children living in extreme poverty. There are still 6 million children 0 to 5 who die every year for completely preventable causes. And those have to do with poor nutrition, diarrhea, and other kinds of exposures. The 6 million is just the tip of the iceberg, though, because we have recently calculated in a Lancet series about early child development that there are 250 million children who are not reaching their developmental potential. So this is 0 to 5-year-olds who are living in poverty or who are stunted, suggesting that they have not received the appropriate nutrition or care that would have allowed them to reach their developmental potential. Now you can imagine at a country level, at an individual level, this is very detrimental, but at a country level, to have a large percent of the population not reaching their developmental potential, not on their optimal trajectory for development, not participating optimally or adequately in the labor force, it has very significant consequences. Now, I don't need to tell you that this is a problem also in the United States. Dr. Christopher mentioned these statistics too, that 1 in 5 children live in poverty, but this goes up to more than 1 in 3 for Hispanic children, American Indian children, and African American children. This is a huge number of children and a large percentage. You can see in the state of California alone, I'm not sure you can see the numbers, but the darker counties are the ones with 20 to 25% of children living in poverty. And the lighter colored ones are where it's 5 to 10%. So California really is in bad shape and ranked second out of 50 states in terms of the percentage of kids who live in poverty. So we really have a long way to go in terms of thinking about children's development and what that means for the state and for the country that children aren't reaching their developmental potential. So I'm going to talk today about 3 questions and try and give some insights in my work, from my work in a global context, that I hope that we can incorporate into our thinking. First is, how do economic, environmental, and social factors shape early child development? So that's something you've heard about already today, and I will add some research to that and some findings. The second is, what intervention approaches can be used to improve outcomes for children? And I sincerely hope to provide you with studies that don't just end with more research is needed and more studies are needed, because our goal in intervention research is really to figure out what's going to work best. And then third, I'll talk about conditional cash transfer programs, which are poverty alleviation programs that have started in Mexico and Brazil, and now there are 30 of them in 30 different countries around the world. It's not something we've done in the United States, but I think it's something to think about as a potential. So to start with the first question of economic, environmental, and social factors, I'll start with the concept of nurturing care. So in this 3-paper Lancet series on early child development that we just recently published, we use this term to encapsulate everything that a child needs for optimal development. So this means nutrition, this means health care, this means love and security, protection from danger, and opportunities to learn and discover the world. And nurturing care is really fostered by a good environment. So you can see in the darker circle that nurturing care provided by parents and caregivers. So their capacity to provide that nurturing care really depends on their own well-being, their own safety, their own security and integration into the community. Then you might have health, nutrition, education, and social protection services, which have to do with the community or the county or the state level commitment to that kind of care. And finally, you have national policies, which can support the promotion of nurturing care. We can think about this nurturing care at multiple levels because it allows us to think about different kinds of interventions for children. Because you can imagine interventions at each one of these levels. You could imagine individual interventions operating at the family and household level, and you can imagine policy level interventions that operate in terms of thinking about minimum wage or living wage, which is something we evaluated in Dominican Republic, or conditional cash transfer program, which again has been taken up by many countries around the world. Thinking about nurturing care in context, I won't go into the details because you can't see the details, but I will tell you that the point here, you have learned about the life cycle in here today. So that's the circle at the top, which is really representing that a child is part of a cycle, and we can't really just focus on the child without thinking about then that child growing up to an adult who then has a child. But really this idea of nurturing care, and those green boxes represent the different sectors. So we have the health sector, nutrition sector, safety and security, responsive caregiving, and early learning, and that each of those sectors are supported then by an environment that allows them to be successful. So again, this is why we have to think about, when we think about interventions, thinking about multiple levels of intervention, that it may not be enough to think about iron and folic acid for a woman who's not able to find those nutrients that she needs. It may not be enough to say, to provide her with vouchers to buy fruits and vegetables if she can't actually find any fruits and vegetables to buy with the vouchers. So that it's really this balance between providing an individual with what they need and then supporting the environment to meet that individual where they are. So in terms of thinking about child development and thinking about timing of intervention, we know that there's a genetic blueprint in the embryo and fetus that establishes these broad strokes of development, and you've heard about this already today, so I don't need to belabor the point, but this idea that the environment modifies this blueprint during critical periods of development is really just to reinforce this idea that children are very vulnerable and that they're on a trajectory of vulnerability, and there are specific domains of vulnerability. And again, how does this relate to interventions? Well, often we like to think that the earliest we can intervene possible, then you have better consequences for the developing brain. So to show you the specific domains of vulnerability, if you can see the x-axis here is time. And it's not a consistent x-axis, so it starts out with conception on the far left, up to birth, and then months up to age 2, and then years, and I don't even want to put myself here because it gets into the no man's land far, far to the right of where those of us over 20 are past there. So you can see here that we have an emphasis on the first 1,000 days in nutrition, because that's including conception, from conception all the way through the first 2 years of life. And we know that by the time of birth, this statistic really surprised me, but it does make sense that we have, so between conception and 4 weeks, you have over 250,000 new cells formed every minute. By birth, there are around 100 billion brain cells, so as many stars as there are in the universe. So this is really a phenomenal number to me, representing how vulnerable those children are and how important it is to invest in brain development early on. I'll finish with this slide just to say that we do know from studies of poverty in the United States that there are specific domains of vulnerability for children. Neurologic vulnerability in brain regions. There's the language region and executive function. And both of those systems are systematically worse off in children growing up in poverty. These are good studies, longitudinal studies showing and measuring brain development and showing that they have a more protracted course of maturation, so that means that they have a longer time to be influenced by poverty. What you see in this graph are the different phases of development. So you can see this is the seeing and hearing, that's receptive language, and the higher cognitive function. We really focus in the first 1,000 days when we talk about nutrition, but there are opportunities. This slide should be also an optimistic slide, because there's also a lot we can do even after the first 1,000 days are over. We focus on the first 1,000 days because in terms of thinking about linear growth and stunting and nutrition, it's often considered to be said and done by the age of 2, which is extremely demoralizing to think that all the interventions in terms of height are done at the age of 2, and that really there's not a lot you can do after that to influence linear growth. But on the upside is that we have opportunities to invest in child development and the promotion of language and executive function and other higher cognitive functions for much, much longer period of time. So just to say about environment, that we know a parent's health and well-being even before pregnancy are critically important. So we have parents' health and well-being, we have the pregnancy environment, and the environment in infancy and childhood. And we spent some time reviewing this literature in the Lancet series because more and more data are coming out about how critically important that is. And furthermore, that the health of the mother and the health of the father, including these multi-generational effects, have influenced children. So we have a life course approach, which I think you also heard about, and I will then just end this segment answering the question of what do we know about economic and environmental, or I would say just let me focus on economic. I can't say that word environmental in here because I feel you all know a lot more about that than I do. So let me just focus on wealth and education to say what we know about the effects of wealth and education are that children from relatively richer households or with better educated mothers perform better across multiple domains. We know this from the United States, and we also know this from rural Madagascar. Interestingly, I did a study showing that we found this very same trends, even among a population that you would imagine would be uniformly poor. I actually found differences across education in terms of maternal education, and having even a little bit more wealth would allow those children to thrive in an environment of extreme poverty. We also know that these differences get bigger across childhood. So what starts out as a small difference, and which has been noted in the United States among children, particularly those living in extreme poverty and also just in ordinary poverty, that there are differences at birth and that those differences just get larger over time. And at some point, they become almost like fixed trajectories of development. The third thing I would say is that the children in rich and poor contexts are as different from as early as 6 months. So that we do, it starts out, for example, I did a study where there was a similar type of study in the United States, but I did a study in 4 different countries measuring children as early as 4 and 6 months and then following those children over time and showing that there were differences in terms of cognitive and language function as early as 4 months. Again, in contexts that you might consider to be pretty uniformly poor. But finally, on the upside, that parental stimulation explains about 20 to 40% of these associations. So this means, how is it that wealth or education is affecting child development? What is that pathway? And a big part of it has to do with how parents are using their time, how parents are using their money, how parents are using their own ability to provide that nurturing care and responsive stimulation to children through books, through toys, through outings, that those are ways, thinking about intervening, those are cheaper, more direct ways to think about providing that support for parents than necessarily instituting an entire income support program. So I'll review now the intervention approaches that can be used to improve outcomes for children. And I'm going to be, like I said, I'm going to be summarizing what came up for us in our systematic review of the literature. And so this is a real scientific-based review that I'm providing for you. And I hope that, and then I'll talk in more detail about conditional cash transfer program. So in terms of thinking about what do we mean when we intervene, what we're trying to do is to get children off of the red trajectory onto the blue. So what you see here, again, on the x-axis is time, starting at prenatal, birth, early childhood, adolescence, and adulthood. And on the y-axis is performance. It could be behavioral competence, it could be brain function. You can think of the y-axis in a whole variety of ways. What you can see here is that if you're on the green line, this is optimal. This means that even if you're exposed to risk factors, which all children are exposed to some kind of risks, but the fact that you have a protective factor can outweigh that. The breastfeeding example, breastfeeding is a perfect example of a protective factor, which even for a child who who may be exposed to other risk factors, breastfeeding can be protective for them. So the idea then with the red line is that the risk factors are outweighing the protective factors, and any kind of intervention we're talking about is that blue, the increasing, trying to shift you from the red line to the blue line. I'm going to give you the summary in a minute about all the evidence-based interventions that work, but here in this red-orange circle is really what we're talking about, the reduction of risk factors. So that interventions, you could consider them to be reductions in risk factors, increasing protective factors, or also thinking about the sensitive period. Like I mentioned in that graph with all the waves, those are representing sensitive periods for particular domains. So this is a timeline and a summary of the evidence-based interventions that are reviewed in the Lancet paper. And it goes from, again, this really should be in a circle because it just basically continues, and that's why the arrow goes in a circle like that. But you can see, again, these are the ones that we know work. So for example, in adolescence and adulthood, family planning and then preconceptual nutrition having to do with improving birth outcomes. All of this related to birth outcomes, increasing survival, and then also increasing thriving among children. And we go through a variety of different kind of health interventions, routine antenatal care, maternal infection prevention. I'm having trouble reading it myself. Assessment and management of fetal health and growth. So there's a whole range of these, and I'm happy to share this paper with anybody who's interested in reading more detail about these. I will focus for the time being on what we can do to promote child development. By that I mean language and cognitive development, although a lot of these have to do with promoting surviving and also promoting thriving, and moving some of our thinking from just this idea of survival to also shifting to thinking about thriving for children. So I'm going to focus on a few that are related specifically to child development. The ones that we reviewed and that were found support for were parenting programs and family support, preschool and other center-based models, social sector support, and the example there is conditional cash transfer programs, some evidence of media interventions, and also integrated approaches. Integrated meaning kind of a whole child approach to saying, thinking about immunizations and nutrition and family support. So in terms of parenting, what does this mean? Parenting interventions in the context, in a global context, fall into a few different categories. One kind is home visiting, and we have examples of that in the United States too, where a community health worker comes to the home with a child, and it's age specific, and that home visitor would help promote responsive parent-child interactions, increase attachment, encourage learning, encourage positive discipline. So what we found is that home visiting programs can be very effective, and that there's a growing literature on community-based parenting support too, which is a more scalable approach to providing parent support, so that they would, in the example I'll show you in Mexico, where parents would all come to a community center, and they would then learn those tools and skills in that community center, and they would come back on a weekly basis and get those tools and skills. I think the thing that we have the closest to this in some ways, and this I think also the community part, your talk made me think about some of the ways that those health programs are integrated and providing community support. For example, the prenatal community support, and also the WIC programs and the way those can bring women together. There was also strong findings in terms of benefits of preschool. So that preschool attendance was associated with higher scores on one or more measures of child development, so literacy, vocabulary, mathematics. But there's a real caveat here, which is that it has to do with the programs being of high enough quality. So that if you had high quality programs, and this is defined as having more teacher training, better materials, greater direct interaction with children, and I would say the other thing we found was that the ones that target the most disadvantaged children also had a bigger effect. So I think that those kids who were not getting those tools at home, and I would say too that these are similar to what we have found what has been found in the United States. So finally, to think about interventions, like I said, we've just completed this giant review. There's a very large literature about what can work in interventions and a good evidence base. And I would say the real challenge now is to think about scalability. So how do you provide preschool, high quality preschool at scale? How do you provide home visiting programs at scale without compromising quality? And how do you find the most vulnerable children? The final question that I'll address today is the idea of the conditional cash transfer program. Has anybody heard about these programs? Many. Okay, good. Not just from me, other places too. Okay. The conditional cash transfer programs are when cash is conditioned. In addition, so families have to satisfy a selection criteria. So it may mean that they're very poor, but it depends on how every country has its own way of defining that. Beneficiaries are required to regularly undertake some pre-specified action. So this being, I'll tell you what the requirements were in Mexico, but often it's attending health checkups, keeping your kids in school a certain amount of the time. And governments use CCTs to transfer cash to poor families, but then they have to comply with these conditions. So there are also other countries that are experimenting with unconditional cash transfer programs, and those have to do particularly with, for example, staying STD negative or HIV negative or not getting pregnant. Like those very specific targeted behaviors are often unconditional cash transfer programs in the sense that they may not involve the whole entire infrastructure of a conditional cash transfer program like this. The point is that many countries have taken these on as incentive-based programs. And I'll show you this chart, which you may have seen, developed by Jim Heckman in terms of thinking about the rate of return to investment in human capital. So here, again, on the x-axis, you have age, and you're looking at the investment and what the return on that investment is. And this is reinforcing the point that I was making, which is that earlier on, you're going to get a bigger return on your investment the earlier in a child's life, if you're investing in preschool programs, then in schooling, then later on in job training. And so I would say to add to this curve, the parenting programs, early nutrition and health, continued nutrition and health interventions, the CCTs really try and address all of those and really try and address those early on. In terms of a theoretical framework for why do we think a CCT might work, you can see here these pathways, and again, this will look familiar to you if in terms of thinking about allostatic load, thinking about poverty, thinking about depression, thinking about all of these risk factors for children. You can see that you have a cash transfer here. So if we just start on the left, the conditional cash transfer program, cash transfer here, so, and the conditions. So the idea is that parents are going to increase their investments in children, that they're going to possibly have decreased emotional stress or depression, and then that will result in a parent's ability to improve, to purchase basic needs, and invest in the child's future, such as purchasing assets or supporting schooling. And similarly, if with decreased emotional stress, you would have more nurturing, responsive parenting, more focus on children. And then on this pathway here, the conditions, you have a direct provision of medical care, nutrition supplements, prenatal care, and vaccines. Again, you would have increased knowledge through education because there are some parent groups and getting the parents together for education, and that these change in parenting behaviors would then improve development. So now I'll show you what the requirements are. They might look a little onerous the first time you see them, but you can see here that children and adolescents have to participate in prenatal care, growth monitoring, immunizations, a whole range of stuff. Under 4 months, from 4 to 23 months, from 2 to 19 years. Pregnant women need to get prenatal care. Adults need to get care. So there's a huge range of health requirements. And you can imagine that this could seem onerous, but then you might ask yourself, maybe you'd be willing to do it if somebody increased your income by 25%. Maybe 30%, depending. So there are, what would you do for 25% increase in your income? All of that and more. So I think that it's, so that's really the question is with CCTs. In Mexico, for example, they consolidated all of the welfare programs and did increase income by 25%, and then that was the reason that there's a very high compliance rate, like over 98% in this program, and this is part of the reason that everybody was so excited about CCTs when the first findings came out. So I will show you just the highlights of what we know about the Mexican program. I can answer more questions about CCTs, but we know that conditional cash transfer programs, participation in those programs in early child development, that there's improvements in height for age, increase in verbal performance, increase in cognitive performance, and a decrease in behavior problems. And so these findings are the 8 to 10-year-old findings. We also know that these findings existed at age 5 and are now planning to do a follow-up of these kids who are now teenagers. We know too that CCTs reduce maternal depression in Mexico. You can see the mean and the control comparison group here of the depression scale, so that there's a significant effect of participation in the cash transfer program, which really had no specific target to reducing depression, had a big effect on maternal depression. And I know you heard about cortisol earlier today. We also found that conditional cash transfer program in Mexico reduced child cortisol. So, and this was specifically significant in children of depressed mothers. So there's a way that children of depressed mothers are more sensitive to context and were more vulnerable to this and were able to benefit more greatly. So in terms of what do we know about this Mexican CCT and child outcomes, There's program effect of better child behavior, greater height for age, and lower salivary cortisol, especially in those of the depressed moms, and also a cash effect having to do with families that got more cash for reasons of household composition. And there was improvements in height for age, cognitive and language function tests, body mass index, and a reduction in behavior problems. So there's effects across the board. And again, when Mexico's conditional cash transfer program started in 1997 in Brazil, there were just 2, and now there's dozens and dozens of conditional cash transfer programs. I'll just end by telling you about an innovation that we worked with the Mexican government to provide more parenting support within the CCT, and I'll show you what those results are. So I will tell you that the way that this worked was a 3-arm trial where we added participation to a parenting support group. This is one of those group-based ones. And then compared ones where the mothers were strongly encouraged to go to the groups, whether they could voluntarily go to the groups, or whether they didn't have access to any kind of groups. So this is kind of that parenting support weekly groups. This is just an example of kind of what the instructions were to for the community health workers. They basically were instructed to talk to parents about singing with their children, engaging with their children, using opportunities such as diaper changing to talk to their children. There's a huge manual of skills-based discussions that the community health workers would have with the parents, and we assessed the children in terms of the McCarthy scales of children's abilities. We found that this group where they were encouraged to go as opposed to where they were allowed to go voluntarily, I don't know what this says about the coercion within this program, because people do interpret CCTs as coercive in some ways, but this group that was encouraged, and some of whom thought it was a requirement of the CCT, were the only group that showed any benefit of the group program. So we were calling it compulsory or encouraged. This was the group that perceived that it was part of the program, and we did not find any effects in terms of the volunteer group or in terms of the control group. So what do we learn about this? What do we know? So this evaluation showed benefits on child development outcomes. It also showed benefits for those who are in the lowest quintile, significant and positive effects. And it really represents this kind of innovative thinking, a great opportunity to affect, I'm so close to my final slide, just the next one, to affect child development. But we think, and we've been working with the government to try and develop what can we do to do more in terms of the program, and to try and get away from this idea that it's something that you're required to do and something that parents are volunteering to do, possibly. So that's another next step. So I hope that I've addressed these questions today, at least in a cursory way, within the limits of time, and I'm happy to take more questions. I'll leave you with my conclusions and kind of next questions. We know that children in poverty are at risk for inequality, especially in these domains of language and executive function that are so critically important across the life course. This idea of how early the gradient starts and in what domains is still an outstanding question, and what are these implications of these gradient in later childhood, and what does it mean for interventions that there's particular vulnerabilities at particular times. Another pressing issue from my perspective has to do with maternal depression. The more and more we see about the significant consequences of maternal depression. So can programs to improve child development simultaneously be adapted to address maternal depression? And on the contrary, could social support programs have a kind of an inadvertent effect on child development by improving mothers' mental health? And then we know that there are several promising programs and policies targeting early child development, and the question is how to bring these to scale without compromising quality, and how to make them most cost effective so that we can address this issue of so many children, such a large proportion of children living in poverty and suffering from the consequences of poverty. So none of this work would have been possible without many, many collaborators and students and colleagues. And I thank you. And there's my contact information if you want to ask a question or get in touch. I would love to hear from you, and I'm happy to take questions now. So thank you.